Welcome back to Psychiatry Boot Camp. A season on Consultation-Liaison psychiatry would simply not be complete without an episode on delirium. Dr. Mark Oldham, in my personal opinion, is the world's leading expert on delirium, and he provided us with a masterclass in Season 2. I have remastered it here and split it into 2 so that it's a little more digestible and approachable for you. I promise you, if you are interested in delirium, this episode does not disappoint. Dr. Oldham will be back next week to teach us about catatonia, so this episode on delirium is a bit of a pregame to get us hyped for what may be the most spectacular episode of Season 3. Diving right in, welcome to Psychiatry Boot Camp, Dr. Mark Oldham, and I will ask you to introduce yourself to our audience.
Sure. Thank you so much. My name is Mark Oldham. I'm a consult psychiatrist at the University of Rochester Medical Center. I'm currently an assistant professor, but imminently to be associate professor of psychiatry. I'm passionate about delirium. And as pertains to our conversation today, I'm the president-elect of the American Delirium Society. So yeah, delirium is definitely something I think a lot about and something I'm excited to talk about today.
Wonderful. Well, congratulations on your promotion, and thanks for making the time for this. So when I was researching this topic, thinking about expert guests, I got to tell you, your name came up everywhere. And then I looked you up on Twitter, and it's very clear to me that delirium is a very special topic to you. So I'm interested, how did it come to be that you decided to focus so deeply on delirium?
Yeah, no, I like the question. So my name, I guess, was coming up because I just keep talking about it and don't shut up. So no, I think delirium represents in many ways why I went into consultation liaison psychiatry. So I went to med school because I wanted to be a psychiatrist, and I knew that to become a psychiatrist, you had to go to med school. I knew very little about medicine at the time. I'd never really met other physicians, no physicians in my family. And I said, well, I need to go to med school. I was fascinated by the interaction between the brain, the mind, the experience. And I thought psychiatry offered all of that in a very kind of a very clinically based context. And I really appreciated that vision of psychiatry. And then when I got into medical school, the very first rotation that I did was in CL psychiatry. And it clicked. And I said, okay, this is what I want to do. And then as I was working in the hospital, even I think the first and second year of med school, saw patients with delirium. And it was so compelling to me to think that something in the body is happening. And in this dynamic relationship between the brain, the mind, the body, the medical condition could mimic essentially any psychiatric symptom that we see in any of the many psychiatric conditions that we recognize in the DSM and beyond. And it was something that was compelling. And then as I began reading about it, I found that I was late to the party because Zbigniew Lepowski had written a beautiful treatise in the introduction to his first of 2 monographs on delirium, where he explored this idea that delirium is an experiment of nature that teaches everyone about these relationships. Delirium is in itself a prototype to understanding many of the ways that brain networks relate to other physiological processes throughout the body and lead to changes, alterations in sleep-wake, in consciousness, in mood, and perceptions, and the like. So yeah, I just find it endlessly fascinating as a model, and certainly from a clinical perspective, very much drawn to help people who are cognitively vulnerable, those at risk for delirium and those with delirium, and then finally improving the outcomes of delirium itself.
So it sounds like you're saying you see delirium as almost a prototype of what it means to have a psychiatric illness.
Yeah, yes, in a way, yes. I don't know if I would call it strictly a psychiatric condition, and I don't know that I would call it strictly a medical condition. It's both and it's kind of neither nor. And when we are on this kind of razor's edge of what is psychiatric and what is medical, our language fails us. So historically, the subspecialty that I'm in was called psychosomatic medicine. And that term means something different internationally as well, outside of the US, as I'm understanding and finding and reading more about this. But essentially, you have the mind, the body, and we know that the two are in dynamic relationship. And so delirium kind of, it illustrates, I'll say it's illustrative of this relationship, and it spans the two in a compelling way, in a way that I feel like is undeniable. And there's something about that, again, that I find compelling and that can teach us quite a bit about perhaps other mental health conditions and the way that the mind and the body relate.
Perfect. And you just kind of got to this. You called it a razor's edge. So I'd love to know if delirium is a medical issue or a psychiatric issue, but it sounds like you're telling me that answer is not going to be so simple.
No, it's not, unfortunately. I think it sits right on the edge. Even when you look, for instance, at the way that the legal considerations might bear upon medical care in the hospital, there's public health law that might address medical sides of things, and you have kind of mental hygiene laws in different statutes that come to bear on patient care and protecting patients and informing care. Very often the two are in their own silos. And a person with delirium, when you look at where does a person with delirium fit, there's enough there that kind of pulls the person away from the protections that medical kind of public health law would provide. And there's enough medical there that pulls them away from actually falling under mental hygiene laws to protect people when they're making decisions that might otherwise be disastrous or dangerous to themselves or to others. And so there's enough there to push it nicely out of the purview of one or the other, but there's enough there that it kind of sits squarely in both. So I think this is a condition that defies a clean categorization in that regard.
Okay, so here's another question that comes up a lot, I think, throughout medical training. We mentioned kind of the medical side, the psychiatric side. Obviously, neurology is very involved in these cases often as well. And I'm interested, what is the formal difference between encephalopathy and delirium?
So I'm going to have to point to a recent position paper. Arjen Sluiter and colleagues published a paper in 2020, and I really like this paper. This has been somewhat of an inspiration to me the last few years, really working this out. What are the natural conclusions of this position paper? But essentially 10 different organizations, 10 medical organizations came together and kind of put a stake in the ground to define encephalopathy and delirium and kind of the delirium spectrum. And they describe encephalopathy, or acute encephalopathy, I should say. And in Europe, I think they call it encephalopathy. I don't hold that against them. But so encephalopathy is the pathobiological brain process that occurs over the course of 4 weeks or less that presents clinically as the clinical spectrum ranging from subsyndromal delirium all the way to coma. And so the clinical phenotype that we see at the bedside is definable, it is operationalizable, and it is reliably detected. And we know this because we can identify specific cognitive, behavioral, and other features that are allowing us to provide a diagnosis. So subsyndromal delirium is the condition that is somewhere intermediate between kind of healthy and delirium, unimpaired in delirium, that represents some, but not all, of the diagnostic criteria for delirium. Delirium then is defined, be it in the DSM-5-TR, the ICD-11, something like that. It has a very clear kind of clinical phenotype, and then obviously coma, moving into coma, kind of unresponsiveness. But pathobiology, specifically the pathobiology that presents at the clinical state is the acute encephalopathy. So the word encephalopathy implies, but does not directly define what the clinical phenotype is. Because it can present as a spectrum, right? So we know that it presents with air quotes confusion, but it can range pretty widely from subsyndromal delirium all the way to coma.
Gotcha. So you may have a patient who could be clinically called encephalopathic, who is not necessarily meeting strict criteria for delirium. Is that right?
Absolutely, yes. So we can work the arrow both ways. So as you're saying, a person can have an encephalopathy, an acute encephalopathy, but not meet criteria for delirium. That is, their clinical state is, like, let's say, less severe than delirium. So they have subsyndromal delirium. Or let's say they are essentially unresponsive. And so now they have coma or near coma. They have encephalopathy, but they don't meet criteria for delirium because the clinical state is not meeting criteria for delirium. On the other hand, a person who has the clinical diagnosis of delirium according to the DSM or ICD, by definition, has an underlying encephalopathy. It's simply that we have kind of drawn lines in the sand, as it were, around the ground beneath delirium, the clinical phenotype, that is encephalopathy.
That is crystal clear. And we are in the business of drawing lines in the sand, I think, in psychiatry. So next thing, how do we diagnose delirium? That is, like, how do we define it and how do we diagnose it in our patients?
Sure. So referring again to the DSM-5 TR, delirium is diagnosed based on an acute change in mental status that is changed from baseline. So this is not the individual's known cognitive personality baseline, what have you. It presents with an acute change or a disturbance in attention, a disturbance in awareness, and at least one other demonstrable cognitive deficit or a deficit in a specific cognitive domain, which could be orientation, memory, visuospatial performance, what have you. So, I mean, essentially, those are all A's: an acute change in a disturbance in attention, awareness, and another, which I hate that, that's another A, but another or at least one cognitive domain. And then in the DSM, we have two other considerations. One is rule outs. So it cannot be due to essentially dementia or an evolving dementia. And then the final one is one has to attribute the clinical phenotype that you're seeing to the direct physiological effects of an underlying condition. So whatever the proximal precipitant is, right? So and that's important in a sense because there are some other clinical conditions in psychiatry that can look very much like delirium, but not be delirium. So some presentations of catatonia can be somewhat challenging to differentiate from delirium. Most of them are not, but some of them can look a little confusing. Some individuals who have disorganized schizophrenia, disorganized psychosis broadly, there are a few dissociative states that can be very challenging, like Ganser syndrome or other states like that, functional cognitive impairment that can look like it. I mean, so barring those conditions, there needs to be a clinical presumption or attribution to an underlying physiological cause.
Do we need to actually know what that precipitant is in order to make the formal diagnosis of delirium? Is that what you're saying?
So there are ways of, I mean, according to the DSM, you can
Yeah.
diagnose it without it's implied, and you know the clinical phenotype so well that there's no question. And if you
Right.
ever really wanted to test it, you could do an EEG and you could demonstrate the classic kind of slowing on EEG. So you don't need to have identified it. One can have it as a presumption based on kind of the overall convergence of all the other clinical factors. And most of the time we find the cause. Some of the times we don't. And that's really kind of frustrating and stymieing for us clinically as clinicians, but also, and even more so, the patient and their loved ones, right? So we'd love to be able to hang our hat on that, but you can diagnose delirium presumptively without the known cause.
Perfect. Are there any specific clues from the mental status exam or when you're evaluating a patient in the hospital, specific bedside tests that you like to do when you're assessing the patient and considering a diagnosis of delirium?
Sure. So usually, but not always, it's obvious. Usually delirium is clear and clear cut. I think really when it comes to the kind of the more challenging differentials of some of the conditions that I've already mentioned, so disorganized psychosis, I'll add into that list mania, this kind of idea of delirious mania, and so forth. I think those might be where some of the additional tests might be really helpful. But I mean, yeah, I would always do clinically the hallmark finding of delirium is a disturbance in attention. And a disturbance in attention can present in a number of different ways. So one would be focus or direct attention. The second is sustaining attention. And the third is being able to switch attention. If a person cannot even engage in the conversation, like they cannot even, let's say, make eye contact and engage in the conversation because they're incapable of orienting to a kind of an environmental stimulus, namely me as the interviewer, the clinician, then that itself indicates inattention. Next is the ability to sustain attention. And so we test sustained attention by way of bedside tests. So things in the ICU, like the Vigilance A task. So that's saying, squeeze my hand when you hear the letter A, and then doing Casablanca or another sequence of letters, and they should squeeze when you say the letter A, but not on other letters. There are other tests of attention like reverse digit span, so giving sequences of numbers and having them repeat them in backward order, giving the days of the week backward, the months of the year backward. Each of these requires taking a chunk of information and focusing on it long enough to provide it backward, or sustain attention on the task long enough to provide the appropriate or correct response. And the third is being able to switch attention. And so if you're unable to shift or switch attention, we call that perseveration. So if a person, if you say, where are you? And they say the hospital, and you say, what year is it? And they say the hospital. And they say, give me your name. And they say the hospital. That's perseveration. And so they're unable to update their attention on a new conceptual stimulus, this new prompt that you're giving them. And so that would be evidence of inattention because they're unable to shift attention. So I would say my clinical tests really focus on attention. If they have impaired attention, usually one can almost infer that they're going to have deficits in higher order cognition, like the registration of information for memory or the recall of that information for memory. Or if you're not oriented to the environment appropriately, then you're almost always going to be disoriented to some extent, right? So these higher level deficits are predicated on these lower kind of core cognitive abilities of paying attention and simply having what we call a clear sensorium, being able to interpret the world around you in clear fashion.
So those are some ways that you would get that very fundamental foundational criterion of inattention in terms of diagnosing the full syndrome of the clinical entity that we call delirium. Any standardized instruments that you'd recommend we consider reaching for?
So as a physician, I don't know that I personally tend to use a lot of tests to augment my own clinical care, although sometimes I do, but usually I don't. Usually it's a clinically invested, rolling with it kind of evaluation, because I think clinical work is very Bayesian, right? So we start with our priors and then the information in front of us, then it changes the way that we engage with the patient. And so we might move in this direction if we see this, or we might move in another direction if we see something different. So clinical care, I think, is a little different, I think, in our kind of logic and thinking about, again, likelihood ratios and applying those to our priors, to posteriors, and so forth. But for, let's say, for research, or for those who might not be as familiar with the mental status exam or neuropsychological testing, there are a number of tests out there that are standardized. So a few things about that. One, the confusion assessment method, or CAM, I think is very often the most commonly kind of referenced, the most commonly known. There's great awareness of that as a delirium screen. It's 4 criteria. So acute change or fluctuation, attentional impairment, we'll say a change in arousal level, and then fourth, a gross cognitive impairment or cognitive thought disorganization. And you have to have 1 plus 2 plus either of the others, the change in arousal or thought disorganization. So that's the diagnostic algorithm. But what should be appreciated when using the CAM is that reliable use of the CAM requires cognitive assessment, dedicated cognitive assessment. It's not something that one can just say, oh, I just talked to the patient, now I'm going to score these 4 elements. When you look at the literature, how it's validated, it's a great tool, but it should be used in the way that it was validated. There was originally a long form CAM, which was a longer interview, kind of a semi-structured interview to ascertain the different parts of the CAM. The long form CAM actually has 10 elements, but the 4 of them are the diagnostic piece. Then it was operationalized as the 3-minute diagnostic interview for the CAM, or the 3D CAM. I personally like that one in general medical patients. It's pretty efficient. It's intuitive. There's a structured section at the top of very specific kind of orientation and attention type questions, a range of observational items, and then based on your answers to these, again, it's a standardized way of administering and scoring the CAM. So the 3D CAM I like. And then there are two other forms of the CAM that are commonly used. One is the B CAM, or the brief CAM. This was originally used and developed for the emergency room for a more rapid assessment for delirium. And that's a standardized way of scoring the CAM. And then finally, there's the CAM ICU, or the CAM for the intensive care unit. And then it also has a worksheet that you follow. And then it's actually, you start with arousal level. And so if you have a RASS, or Richmond Agitation Sedation Scale score of -4 or -5, you can't score it. So it's an unscorable. So it kind of has that skip criterion, if you will. So those are three ways of standardizing the CAM. There are a few other ones that are used clinically that I think are important to at least consider. One is the 4AT, or the 4A's test. This was developed, I believe, originally in Scotland, and has really seen a great deal of usage internationally. I think increasingly in the US. More recently, I've heard of some institutions using this, but it heavily emphasizes the role of a change in mentation and also a change in arousal. If either of those is present, it essentially is positive. So I think it ends up being a lot more sensitive clinically in the course of routine clinical care, because those are two things that are pretty obvious, and you already get a presumptively positive 4AT with either of those without the use of cognitive testing. But if inattention requires on the CAM, in the diagnostic algorithm, inattention to be assessed, and you don't assess it, then it's easy to skip over and say, oh, they're attentive because they said yes or no to me when I was giving medications. And then the final one I might mention is the NUDES, and that's a nursing-based screen, and it's kind of a look back over the course of a nursing shift. And it basically asks questions about whether the person was hyperactive, if they were hypoactive, if they were having psychotic symptoms or perceptual disturbances, things like that. And again, it ends up being a little bit more sensitive because it's a look back, and it really takes a global approach to overall mentation and behavior over the course of that episode, that nursing shift.
Very, very thorough for us. And all of these instruments that you just mentioned, I'm sure, are very easily findable online for our learners. One of the big points you mentioned was taking time to formally assess the various domains of cognition. Throughout training, this is something that really kind of shocked me at first. Was you can have a seemingly normal, superficial interaction with someone, and then you ask them to draw a clock. And sometimes it's like, oh my goodness, if you're not actually doing the test, our gestalt is not necessarily as good as we think it is sometimes. It sounds like for our learners too, you might recommend, as you're first learning how to assess delirium, it might be helpful to get like a 3D CAM, take it to the bedside, formally work through it. Certainly a useful exercise to go through these instruments to give you a better understanding of delirium. But realistically, for a more experienced practitioner who is using the mental status exam several times a day, often you don't actually need to go so far as to use a formal screening instrument. Is that a fair summary?
Totally. I completely agree. Yes.
Okay. So you mentioned screening for delirium in the ED, which makes me wonder, why is it so important that we recognize delirium?
Many reasons. Delirium is important. I guess one thing I'll say even before that, kind of to follow up on your prior point, was open-ended questions matter. So in clinical settings, it's very often that when we engage with patients, there are many different ways of asking a question. You can ask closed-ended questions, open-ended questions, and variably open questions. So for instance, a closed question would be, how many hours did you sleep last night? That's a very specific question, right? They only can give like a number of hours, presumably. I mean, if you're answering the question literally, they give a number. Did you sleep okay last night is a variably open question, because the right answer to that literally is yes, no, maybe. But what you're usually implying is you want to know how they slept. So an open-ended question would be, how did you sleep last night? Or perhaps framing it more as an instruction, tell me about your sleep last night. Something like that. So when we as clinicians use closed-ended questions, we very often can overlook and it can help to belie some of the cognitive impairment that might be present. And there is the patina of clear-mindedness or clarity of thinking, when in all reality, that's not the case. And we've actually injected our own sense of clarity on the situation. We've led them to answers. They've given the answers that we set them up to give. We haven't given them much of an opportunity. So again, I think that's important to consider in the way that we engage. And if a person's always giving short questions, short answers, I should say, it's important to even go back and review the kinds of questions we're asking and maybe now open it up if we really do need a little bit better narrative from the patient. But getting to your question that you'd asked here is, why is it important to diagnose delirium? I think the chief reason it's important to diagnose delirium is if a person has delirium, there is a cause. And if you don't diagnose delirium, then, then you essentially ignore the kind of flashing red light and sirens that are going off in the patient's brain that's trying to tell everyone around them, hey, look, something is not right. So again, delirium is at heart indexing an underlying medical, surgical, neurological condition that is affecting the brain. It is so severe that it has caused the person no longer to be able to think clearly, coherently, cogently, what have you. So the main reason that it's important to diagnose delirium is to find the underlying cause. But then there are other reasons too. So beyond that, delirium has horrible outcomes. We know people who have delirium end up very often having either A, new cognitive impairment after the episode of care. Some individuals with delirium do not get back to their previous level of functioning. So it indicates that there was some neuropathology that progressed during the process of that delirium, in the midst of that delirium. Some individuals have accelerated cognitive decline after delirium. And recently, the 6-year trajectory outcomes of the SAGES study were just published earlier this year, 2023, and found that people with delirium after a major surgery had a 40% greater cognitive decline at 6 years relative to those without postoperative delirium. And so it's important because it also tells us something prognostically. And then I don't mention this last because it is least important, but the patient's experience, right? So someone who has delirium is not living their best life. I've never met the person with delirium who was, and I don't anticipate ever meeting the person with delirium who is living their best life. They're not going out to the park with their friends or their family. They're not at their own kitchen table. They're not watching their own evening shows in their own home, right? They're not spending time doing all the things that they love, whatever hobbies, sports, whatever their interests. So it's important because we really need to pay attention to the distress that patients are having, providing education for families, and really making sure that they have the kind of supportive environment for recovery and safe recovery that we can provide.
Brilliant. So definitely important so that we know to do a more in-depth workup to look for the culprit of what's causing delirium for prognostic reasons, really because, I don't know, to heal the person, to help improve their quality of life, kind of like what we are here to do. Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Psychiatry Boot Camp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner because this is the question bank that I use to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Boot Camp's exclusive additional 10% savings by entering the word boot camp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, bootcamp.
How dangerous is delirium? Or perhaps I should say, what makes delirium so dangerous?
So I guess I'm going to put this in a couple different categories. What makes it dangerous, let's say, just the symptoms of delirium, it's dangerous because I'll use more of a clinical scenario. So if someone came up to me or you on the street and wanted to stab us with a needle, we would fight back, right? So I would not just let somebody do that. I would respond. Now, if you're in the hospital and you have delirium and you don't recognize the people around you, and ostensibly the people around you are trying to help you, but there's this person and you just told them you're at home, even though you're not, so you're disoriented to place and situation, and they're coming at you with a needle or trying to give you these pills that you've never taken before in your life, and they don't look familiar to you at all because when you go in the hospital, they're always looking different, they're formulations, and they start new pills and stop old pills. It's not unreasonable to think that a person with delirium who is not interpreting their environment correctly would react in unpredictable ways, be it impulsively, be it in kind of a defensive way, swatting at people. And so in that sense, it's dangerous because the person with delirium is not going to be making reasonable decisions, behavioral decisions, reactions to people, and engaging with their environment in an appropriate reality-based way. So that's one example, but somebody in the hospital, they don't remember that they had surgery the other day on their hip and they try to get up because they think, hey, look, I should be able to get up. I need to go use the restroom. Not recognizing that they have a catheter and not recognizing that they're in a hospital bed and not remembering that they had a surgery, they get up and then, let's say they're deconditioned or maybe they're a little woozy or they're a little lightheaded or they're in a cast and they just fall, right? So it can be dangerous to the individual because of the decisions that they make. But the other elements of danger, so that's kind of one bucket, like the experience of delirium contributing to the danger. The other way, I think, broadly is the many things that cause delirium are themselves dangerous. And the people who develop delirium generally, but not always, have a certain degree of vulnerability cognitively, physiologically, in terms of frailty, to delirium. And so delirium is dangerous because the person who has delirium has a very significant, very often severe medical condition that is causing damage on its own. And then, of course, if you're not getting up for a little while, you become even more deconditioned. And if you're not eating as much because you don't have the actual kind of initiative to eat, then you become dehydrated, malnourished. You're not getting up and walking, so you get weaker. All of these things, they compound one upon another and lead to worse outcomes.
Worse outcomes meaning much longer length of stay, meaning higher mortality risk,
all of the above. Yeah. So, I mean, it's in some sense, and I say this in all sobriety, that one could pick essentially any outcome they wanted that's bad and do a study and find that delirium is associated with it. Now, I mean, I'm being a little facetious in saying that anyone, but yes. So there are countless studies, scores and scores of studies and meta-analyses looking at in-hospital and post-discharge outcomes. And delirium is pretty consistently associated with worse outcomes across the board. So thinking about in the hospital, greater risk of mortality in a number of contexts, longer ICU lengths of stay, longer intubation, just because let's say the agitation or activation during extubation trials leads to a failed extubation trial, and then they've got to try it again the next day, right? Longer overall length of stay, other complications, hospital complications like falls and so forth. And then outside the hospital, it can be things like higher mortality, greater risk of cognitive impairment, higher risk of institutionalization, so discharge to a location other than home or a higher level of care. So yeah, really across the board, delirium has just a range of really dire outcomes, unfortunately.
How common is delirium?
Too common. Too common. Yeah. So the statistics on this kind of vary depending on the population you look at. And that could be based on, if we look specifically at older adults versus a broader population, kind of an all-comers population. But I think in general, it's usually a conservative estimate to say about a third of older adults who are medically or surgically hospitalized will develop delirium or have delirium at some point during their hospital stay.
Wow.
In critical care settings, again, the statistics vary quite widely, but it's not unreasonable to say that 50 to 70% of people will have had delirium at some point in their hospital stay, those who require ICU level of care. And then, then depending on the surgery we're talking about and the population, those numbers get lower in different contexts. But again, it is substantial, both in terms of the reason for presentation. So it's the thing that really brings someone to clinical care, as well as in the midst of care, as the acuity of illness kind of ramps up, delirium itself ends up happening with terrible regularity.
And that will not be surprising to anybody who works on a hospital consult service. I think that on the psychiatric consult service, this is a lot of what you do. It's the bread and butter in some ways of what you do. And you're talking a lot about how delirium is on the razor's edge between psychiatry and medicine, but really the underlying cause is medical. And that's what we're here to do, is to treat the underlying cause, to alleviate suffering. So why are we as psychiatry even really involved if the foundational problem is medical in nature?
That's a great question. I say that in sincerity because I have often asked myself that question, because I felt almost a sense of kind of clinical nihilism at times. Because on the one hand, if I start trying to tell my medical and surgical colleagues how to manage the very conditions that they're managing, then it can sound rather patronizing. And so you have to step very respectfully and diplomatically into those conversations. And then at the same time, we really lack, I'll say, disease-modifying care. I mean, that I'm just using that as an analogy. We don't really have the delirium antidote as a whole. And there are a lot of reasons for that. I'm sure we'll get into treatment in a little bit in just a moment. But I think a few reasons psychiatry ends up being involved are, one, practically speaking, when somebody is, I'm going to use this as a broad term, altered, they're not acting like themselves, their personality is different. I think a lot of clinical teams are busy trying to save lives and treat patients, and they're not maybe as attuned to or don't have the time to do a more nuanced cognitive exam, mental status exam to really say, is this schizophrenia? Is this bipolar disorder or simply depression? Is it delirium? Is it something different? Help. I think in some sense, the pragmatics of diagnostic clarification is often what might drive a psychiatrist to being involved as a consultant in the medical setting for a person with delirium. Another one is the idea, and this is kind of an idea that I'm trying to pull from the dementia literature. We talk about the behavioral and psychological symptoms of dementia. Delirium has essentially, I'll say, a similar palette of neuropsychiatric disturbances. Now, they're a little different, a little bit more acute, and they can present a little differently. But I think by analogy, delirium has a range of neuropsychiatric disturbances. And it's the disturbances like hyperactivity, agitation, the paranoia, the irritability, leading to care non-adherence, combativeness, impulsivity, and just bizarre or odd experiences. All of those are intuitively psychiatric symptoms.
Totally.
And so And so those are the things I think very often that lead psychiatry to being involved. And in fact, there's only one study that I know of in the entire literature on this. It's a really nice study a few years ago when it kind of looked at kind of what is the breakdown between when neurology gets consulted for delirium and, the delirium spectrum conditions, acute encephalopathy, what have you. And then when psychiatry does, psychiatrists were much more likely to prescribe or recommend prescribing medications. Neurologists were much more likely to recommend workup, be it an LP, brain imaging, things like that. And I think there's probably an upstream reason for that. I think psychiatrists usually get involved when there's a lot of behavioral complexity and neuropsychiatric complexity intuitively. And neurologists get consulted when the person, let's say, doesn't have necessarily, but they could, not necessarily the same behavioral complexity, but there is a diagnostic complexity or kind of lack of clarity. And so the neurology team comes by and they do their neurological workup, their neurological assessment, what have you. And so I think it just naturally works out that way, but that might just be an artifact of kind of recognition and the way that things present.
That is an absolutely brilliant take on that. And I initially I was thinking we're all hammers looking for nails, aren't we? But it's way more complex than that. And I think that you're giving everybody a lot more credit than that. You're saying that the nails, the hardware with which we get presented is very different based upon the specialty that we're practicing in. So it would make sense in a way that our approach would be very different because the substrate is very different.
I agree. Now, I'm also going to say it's probably both and. So yes. So I think the upstream effects really do factor into, who gets consulted and what those recommendations are, because the recommendations should reasonably meet the consult question. But I completely agree with you that if you have a hammer, everything is a nail. And so perhaps, and I mean, I don't know of any empirical data on this, but perhaps psychiatrists are more likely to recommend psychotropics, non-beneficial psychotropics, than other specialties. And maybe neurology is liable to recommend non-beneficial workup more than other specialties. I don't know if that's true, but it's certainly plausible that could play a role as well.
Great thought food there. Thanks for listening to this episode of Psychiatry Boot Camp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.